Thank you, Stephen, and the organizing committee for putting that conference together. Really grateful to be here. As Stephen said, today I'll talk about type 2 diabetes management with different ketogenic approach. So exogenous ketosis and endogenous ketosis. But before going further, I just want to acknowledge the chance of living and doing my research under the ancestral and unceded territory of the Silicon Canadian people. So if you have had the chance to go to Kelowna, amazing place, amazing city, and they got really great wineries. So let's go. So for the first part, I'll talk about how I went from studying exercise to ketogenic approach. After that, we'll talk about endogenous ketosis and type 2 diabetes remission. And finally, with one project, we'll talk about exogenous ketosis and type 2 diabetes management. So I don't think I have to tell you this, but the prevalence of type 2 diabetes has increased drastically over the past decades. Worldwide, every second represented new diagnoses of diabetes. In 2017, it's close to 500 million people across the globe living with this condition. And the estimation for 2045 is around 700 million people, which is 2 times the population of the United States. Unfortunately, Canada is no exception, with 2.4 million people living with this condition in 2015, and we got a 40% increase by 2040. This increase in prevalence is also accompanied with an increase in financial burden with 3.8 billion annually, and people living with type 2 diabetes are at higher risk of comorbidity and premature mortality. But the issue is not just the presence or the simple diagnosis of type 2 diabetes, but rather the inadequate management or treatment of the disease. Let me explain. In people living with type 2 diabetes, it is the presence of cardiovascular disease that really drives this financial burden. It is also the presence of cardiovascular disease that increases the risk of depression and premature mortality. So this is why Diabetes Canada has some guidelines. And one of these guidelines is to reach the triple target that we call ABC. So A is for A1C under 7%, B, blood pressure under 130 on 80 millimeters of mercury, and C, LDL cholesterol under 2. So altogether, somebody that reaches that triple target reduces considerably the risk of cardiovascular disease. And in one of our paper, where we use a Canadian Health Measure survey, so it's an epidemiological study that represents the whole Canadian population, we've shown that only 14% of people living with type 2 diabetes are achieving this triple target. In the same paper, we also shown that people that are more physically active are most likely to reach this triple target. So we can see that people in quartile number 1, so the less active people, are less likely to reach triple target compared to people that are physically active. So this is also why Diabetes Canada suggests of doing 150 minutes a week of moderate to vigorous physical activity. Again, this is to reduce the risk of cardiovascular disease, but just to overall improve disease management. So this is why almost over the past decade or so, my research has been focusing on optimizing exercise prescription for people living with type 2 diabetes. So we've looked at different intensity, different pattern of exercise, different modalities, so resistance training versus aerobic, and also different timing. This is better to exercise in the morning, in the afternoon, before or after a meal. But one thing that really stuck to me in my research was that when you look from an epidemiological standpoint, only 50% of the Canadian population are active enough. And that prevalence is even lower in people living with type 2 diabetes, with around 30%. So even though I have the best exercise modality with the best intensity and the best timing, none of this really matters if people are not physically active. And as a clinician, my goal is to find a different approach. I have different tools in my toolbox to help reduce the risk of cardiovascular disease. So if you look at the literature, you'll notice quickly that ketogenic approach are probably a good way of improving type 2 diabetes management. So this is why, during my PhD, I decided to do an internship in a lab where to study type 2 diabetes, exercise, and ketosis. And quickly I realized that UBC with Dr. Jonathan Little was probably one of the best choices that I had. So this is why I'm currently doing my postdoctoral fellow at this place. So I'm still doing exercise with type 2 diabetes. So we're looking at the effect of exercise snacks. So how doing brief bouts of exercise throughout the day can improve the disease management. But as of now, let's say that my research is kind of split in 2 different categories. The first one will be a low carbohydrate diet and intermittent fasting for the possibility of achieving type 2 diabetes remission. And on the other side, I'm also looking at the exogenous ketone supplementation to also improve disease management and reduce the risk of cardiovascular disease. So my presentation will start talking about endogenous ketosis and then exogenous ketosis in people living with type 2 diabetes. So usually for people that don't know ketosis, I explained this slide briefly. I don't think I have to do it today, but when we talk about ketosis, most people think about the endogenous pathway, where if you do a low carbohydrate diet, or if you do intermittent fasting, you'll start relying more on free fatty acid, you'll produce those ketone bodies, acetoacetate, beta-hydroxybutyrate. But also, I just want to put out there that when you do endogenous ketosis, even though with exogenous acetoacetate and beta-hydroxybutyrates are elevated, it's not the same environment. So insulin is low, glucose is low, which might not be happening with exogenous ketosis. So I just want to say that even though these two strategies might look similar, there's also some difference. So the first project that I want to talk about is the DECIDE trial. So the DECIDE trial is for diet shows to promote type 2 diabetes remission, supported by community pharmacists and registered dietitian. So type 2 diabetes has, for the longest time, has been seen as a chronic and progressive condition that requires medication. But in 2022, Diabetes Canada put their first clinical practice guideline that says that type 2 diabetes remission is possible. So what is remission of diabetes? If you've been diagnosed previously with type 2 diabetes, and you now have an A1C under 6.5% and do not take any glucose-lowering medication for 3 months, you technically achieve remission. And this marks a really pivotal shift in how people see the disease. So the possibility of achieving type 2 diabetes remission stems from bariatric surgery, where 30 to 63% of people after 1 year did achieve type 2 diabetes remission. So over the past, let's say 10 years or so, there's different studies. So there's the Look Ahead trial, there's the Direct, the Diadem, different studies that have looked at different way of achieving type 2 diabetes remission. And most of those studies have looked two different modalities. So either an hypocaloric diet, where people consume very low amount of calories per day, so between 800 and 900, or a low carbohydrate diet, where people reduce their carb considerably, with or without any exercise. But to this day, it is unclear if one dietary strategy is more efficacious than the other for type 2 diabetes remission, and which one might be preferred by the patient. So the overall goal or objective was to conduct a pilot implementation project to test low-calorie and low-carbohydrate diet for type 2 diabetes remission. Our main objective was to look at, one, the preference. What do people prefer, low-calorie or low-carbohydrate? Is there any difference in adherence? And also to just give evidence and determine if one strategy is better than the other for remission and clinical outcome. So this project is currently running in the lab. We're looking to enroll 100 people living with type 2 diabetes. Once they're deemed eligible, they'll meet Jake, one of our PhD students in the lab, and in a non-biased way, he'll present the two strategies. So either you want to do a low carbohydrate diet or a low calorie diet. During both of these strategies during your intervention, you will have meeting with registered dietitian and pharmacists for the prescription. And you can see, so basically, so I'll just put that out, but there's different phases. So during the phase 1, people that are in the low carbohydrate will aim at 50 grams of carb or less a day. And during phase 2 and 3, we'll have carb reintroduction, but still under 120 grams per day. People in the low calorie, same thing, they'll have for the first 12 weeks, they have low calorie diet, so 800 to 900 calories a day. And then we'll reintroduce more calorie for phase 2 and phase 3. So as of now, this is still preliminary data, but I'll present from week 1 to week 12. So as of now, 30 people were enrolled in low carbohydrate diet, and 4 people did drop out of that group. And people in the low calorie, we can see there's 8 enrolled, 3 have dropped out, and 2 have switched. Because during the 12-week, at any moment, if they want to switch intervention, they can. So this is still preliminary, but we can see a massive trend towards low carbohydrate diet. So people in real world settings seems to want to go toward this approach instead of low calorie. When we look at the HbA1c, so their glucose control over 3 months, it seems that both approach might reduce A1c, but it seems there's a bigger decrease in low calorie than low carbohydrate. However, 2 things we have to keep in mind. The first thing is not all patients at the same stage of deprescription. So some people still have medication while others may not have medication. And some pharmacists call them, we like to run them sweet, as sometimes they remove medication and it just takes more time until glycemia gets stable. And also we can see maybe in the people in the low calorie, the baseline value seems to be a little bit higher. If we look at their weight, both strategy seems to be efficacious for reducing weight, with around 11% of their body weight decreasing in low calorie and 7% in low carbohydrate. Again, this is only 12 weeks, so we have to know what happens for the next 52 weeks for a year. Is there a bounce back effect that we sometimes see? Is there still decreasing in people in low carbohydrate? We don't know yet. So again, these are like really preliminary data, but I think as of now, what we can say is that we can show a preference for a low carb diet versus low calorie. Both strategies show potential for remission, but still we have to finish the trial to be certain. And finally, this gives promising insight into a patient-centered, community-led nutritional intervention. So the really cool thing about that project is that it's really embedded within the healthcare system. So it's really pharmacists from the community. So if it's deemed feasible, it's going to be easier to just implement in a real-world setting. But one question that we can ask ourselves is that, is it possible to achieve type 2 diabetes remission outside the research setting? So all the evidence that we have for type 2 diabetes remission have been done in trials, which is normal. But again, when you're in a study, you have your own bias. You know you're in a study, you want to do well. And also, the researcher called you on either weekly basis or monthly. Are you still following your diet? Is it still good? And you know you're going to be tested at the end. So we were wondering, does remission really happen outside the research setting? And we work with a lot of patients with lived experience, and we know that some people are using different strategy with different support from their healthcare provider. So the one question I was asking myself, so back in 2022, was I want to describe the characteristics and lifestyle behavior of individuals who achieve type 2 diabetes remission in real-world setting. And I want to also investigate their continuous glucose monitoring profile of these individuals and explore how different dietary approach might modulate their glucose regulation. So to do that, I did mostly recruitment in DC with healthcare provider and different posters. Once people were deemed eligible, they signed informed consent. We did A1C to make sure they were indeed in remission. We had different questionnaires such as the EQ5D5L, homemade questionnaire about remission. They had a 3-day food log so we can know what they're eating and what's their macronutrient distribution. And finally, they were with continuous glucose monitors, the little monitor that you see on people's arm that measure glucose every 5 to 15 minutes. And this one was the Freestyle Libre Pro, which is blinded to limit any bias. So data collection took place between 2023 and 2024. Overall, we had 21 people that we recruited. Most people were female, diagnoses of around 4 years. A1C was 5.7 and BMI around 30. Really interesting fact, when we asked people how do they achieve type 2 diabetes remission, 48% was only with nutrition and 52% was with nutrition and exercise. But the really, really cool part about that is that we asked a follow-up question, which was, what type of diet are you following? And we can see that 52% were either following low or keto or low carb diet, and 40% were following carnivore or keto bar. So that shows that it's only 21 people, but this is in real world setting. We show that around 66% of people choose a low carb diet to achieve type 2 diabetes remission. And this goes along with the DECIDE trial that we were showing previously as well. Then we can see that no specific diet, 19%, meal replacement, which is usually the low calorie option, around 10%, and Weight Watcher, 5%. When we ask people what is the most important contributing factor in achieving type 2 diabetes remission, it's pretty clear. Number 1 was diet, 2 exercise, 3 was support from their healthcare provider, and 4 was support from their family. And when, this is a little bit more messy, but when we ask people who they contacted when they knew about type 2 diabetes remission, and in number 1, most people were their physician and different healthcare provider. And we have a qualitative study as well, and in that study, it showed that most healthcare provider doesn't know the possibility of achieving type 2 diabetes remission. And this is a real problem because some people want to improve their health and cannot or are not supported by the healthcare provider. So we need more knowledge transfer initiative to really bring that to the general public. So for people that know the EQ5D5L, the last question is basically they ask people how good or bad is their health today. So 100 represent the best health you can imagine, 0 the worst health. And people in the sample were around 80%, which is higher than what we see in different population living with type 2 diabetes. This could be explained that in most, so the diet and trial and the direct, which are 2 trials about remission, once people achieve remission, their self-perceived health is usually higher. And then if you look at the CGM, so the continuous glucose monitoring, in our sample, the mean glucose was around 5 millimole per liter, probably better than my glucose control. Standard deviation was around 1. So how much up and down are you doing throughout the day? So their glycemic variability. Time in range is when they spend between 3.9 and 10 millimole per liter. So usually they're always in range. And if they're not in range, they're actually in hypoglycemia, so under 3.9. The really cool fact is that when we look at individual curve of people, we can see that the first four graphs, the people following carnivore, ketovore, and low carbohydrate diet, they have a relatively flat curve. So there's no glucose excursion for breakfast, lunch, and dinner. However, when we look at meal replacement diet and no specific diet, we can clearly see those glucose spike for breakfast, lunch, dinner. So what we decided, we did some correlation and some linear regression, and we've shown that A1C and 24-hour CGM are both positively correlated to the percentage of carbohydrate from the total amount of calories they've eaten. So that just means that people that are following ketogenic diets, or so either carnivore, ketovore, or low carb, or very low carb, have just better glucose regulation. So overall, that present study highlights the feasibility of achieving type 2 diabetes remission in a real-world setting, and also to add more just active lifestyle. So we just got funded by CRHR for a project that's called Remission Possible. So if you want to talk about that, but basically the only goal of this project is to increase awareness of type 2 diabetes remission across Canada. So we have a really cool website. We have a ton of information. So if you know people, you can guide them to these resources. You probably know, but if you look in the media or anywhere, intermittent fasting and time-restricted eating is now more popular than ever. And when you look at the big trials, such as the DIADEM, the DIRECT trial, you can see that the factor number one to achieve type 2 diabetes remission, the best predictor, is how long have you been diagnosed with type 2 diabetes. So if it's been more than 6 years, your chance of achieving remission is really low. Also, if you're using insulin, also very low, just because in general, if you're using insulin, your beta cell function are almost inexistent. So you're farther along the line of the type 2 diabetes continuum. But we got a really cool case study that is under review in a journal of physiology. It's a 47-year-old female living with type 2 diabetes for the past 15 years. She was using metformin and glycoside. And despite that medication, her glucose was around 12 millimole per liter. So she was actually prescribed insulin for like, let's say, 3 months. But at this moment, she decided to take the matter into her own hand. So she went online to try to find information. How can she improve her glucose control? And that specific study is it's a case study, but in 3 different phases. So the first phase, she's using all of the medication, glycoside, metformin, insulin, and she had no specific diet. So it's just technically your baseline, how much her body was responding. Phase 2 is when she decided to do low carb diet. So she was probably doing keto, so under like 30 grams of carbohydrate a day, try to eat a little bit more protein, try to eat some veggie as well. And then, but she also had all of her medication. Third phase, she stopped all of her medication, no glycoside, no insulin, nothing. And she was doing intermittent fasting. So she was doing 24-hour fast. And when she was eating during that 8-hour period, she was mostly having a low carb diet as well. She did even some fast that went up to the 83-hour fast total. So let's look at the result from their CGM. So during the first phase, we can see average glucose, even with insulin, around 13 millimole per liter, time in range 80%, A1C close to 10%. Phase 2, when she was doing low carb diet, we can see already a drastic change. So all of her time is almost in range. She got a little bit of hyperglycemia for breakfast. A1C dropped down, which is great, but she still have all of the medication. Phase 3, no medication whatsoever. So she's been diagnosed with 15 years, was using insulin, and with what she was doing at the moment, all her time was in range, EA1C under 6%, so she technically doesn't have type 2 diabetes as of now, and she's also average glucose under 7. So that person after 3 months achieved type 2 diabetes remission. One really cool thing as well is we have data from DEXA scans, so before 28 days and 97 days. She lost over 14 kilograms during that time. Half of it was muscle mass and half of it was fat mass. And we can also discuss at the end the clinical implication of losing that muscle mass. But if the strength is not affected, it might not be as big of a deal as we think, but we can discuss about that. And finally, she also lost estimated visceral adipose tissue with the DEXA scan. One finding from the Apple Watch, so it's not always valid in the research, but pretty interesting to see that her resting heart rate decreased drastically, and same thing that your heart rate variability also improved, which are both linked to the risk of cardiovascular disease. So this is only a case study. Oh, okay. So this is a case study, but I think it underlines the possibility of achieving remission with intermittent fasting. And one thing that I find super interesting is that a more drastic approach, so doing intermittent fasting rather than keto, might be an option to put people in remission that are further along the line for their type 2 diabetes progression. Again, we need more randomized control study to confirm those results. And we also need to assess the feasibility and acceptability of combining exercise with intermittent fasting. Because I didn't say it, but that person was doing close to 300 minutes a week of moderate to vigorous physical activity. So she was really active. So as a clinician, if I want to implement that with patient or in research, I need to know, can people fast and also do exercise at the same time? So this is what I'm doing as one of my independent research projects. We're starting with healthy people, but we took 15 healthy people, and it's a crossover study design. They do either 48-hour fast, with all of water only, or 48-hour fast plus exercise. So the main question, slide just changed. Okay, cool. So the main objective of that study is to look at the feasibility and acceptability of combining exercise and fasting. We look at dropout rates, mood, sleep quality, and the pleasure of displeasure while people are doing exercise. So if people do exercise but they feel miserable, it might not be a good thing for long-time adherence. And then the second objective is to see if exercise could mitigate the transient insulin resistance that we see when people are fasting. So I think the first time was in 1958, it's almost 200 years ago. Claude Bernard mentioned it is possible to make an animal diabetic by making it absorb carbohydrate under certain circumstances, namely if sugar is given after 26 to 36 hour fast. So technically, when you're fasting right after a fast, so usually 36 or 48 hours, if you eat any meal with carbohydrate, what you'll see is that your breakfast, lunch, and dinner, your glucose spike and area under the curve will be higher. And one of the questions that we ask is, if we do physical activity while fasting, can we reduce this glucose excursion and usually improve glucose control? So this is a really important question, because if we want to prescribe intermittent fasting for people living with type 2 diabetes, but after the fast we exacerbate their insulin resistance, it might not even be beneficial. So I have some backup slides for that project. So 4 people have done the trial as of now. I just didn't want to include because it was really preliminary, but if you have any question about that project, I have some data about it. So for the first couple of slides, we talk about endogenous ketosis and type 2 diabetes remission. But exogenous ketosis could also be a good way to manage type 2 diabetes. So maybe not to achieve remission, but in the management itself. So one paper from 1944, I think it was the first time that it was shown that ketone bodies, so in that instance it was acetoacetate, if you infuse an animal model, it could reduce blood sugar level, and probably because it increased insulin secretion. So actually, so that in like the next couple, like in the 70s and the 80s, they did some study where they infused beta-hydroxybutyrate in human, and they've shown the same reduction in glucose. That led to the development of exogenous ketones, so clogs in 2012, published the first paper about it, and then there's now a bunch of different companies that offer these exogenous ketones. So it could be ketone salt or ketone monoester. And for the past 10 years, there's now several studies that have used exogenous ketone in humans. So from Dr. Little's lab, Kyle Palkenheim, which works a lot on exogenous ketosis, have done a really great meta-analysis. And they've shown that there's a dose dependent between increase in beta-hydroxybutyrate in circulation and glucose reduction. So the higher your ketone goes when you drink exogenous ketone, the higher the glucose drop will be. The one thing we have to keep in mind is that all of those studies have been done in healthy people or people living with obesity. The question still begs, does that still happen in people living with type 2 diabetes? So there's different potential mechanisms by which beta-hydroxybutyrate can improve or reduce glucose. One of them might be by the increased insulin secretion. So if you increase insulin, glucose will enter into muscle more easily. It will also reduce free fatty acid and then limit glucogenesis. But DeFronzo, the godfather of type 2 diabetes, in one of his papers in 2009, mentioned that by the time the diagnosis of diabetes is made, the patient has lost 80 of her beta cell function. So even though BHB increased insulin secretion, if you don't have any beta cell residual function, maybe insulin doesn't increase. So Sotomoto and colleague in 2021 look at that specific question. So they have 21 people living with type 2 diabetes. They give them 25 ml 3 times per day for 28 days of exogenous ketone. And what they've shown is that fructosamine, which is basically A1C, but for 2 weeks, HbA1c, glucose daily mean, and time in range all improve. So we can say, okay, then exogenous ketones still work in people living with type 2 diabetes. The only problem is that there was no control group in that specific study. So maybe it works, but we're not sure 100%. So Dr. Little did a similar study 1 year later with 15 adults living with type 2 diabetes, but he did a randomized crossover trial with 0.3 grams so 3 times per day for 14 days. And what they've shown is that both fructosamine and A1C didn't really improve it compared to a placebo. But those two studies are kind of acute. 28 days and 14 days is not a really long time. So maybe prolonged ingestion might help reduce chronic inflammation and restore insulin sensitivity and or beta cell function. So usually, like you probably know, but in normal condition, insulin binds to its receptor, then GLUT4 is translocated, glucose can enter the membrane. But in people living with type 2 diabetes, there's chronic inflammation, and there's a bunch of cytokines that are present. Some of them, such as TNF-alpha, can inhibit the connection of insulin with its receptor. So again, from Dr. Little's lab, Elena Newdorf, the PhD student that's finishing probably today or tomorrow, I've shown that beta-hydroxybutyrate could be anti-inflammatory in people living with type 2 diabetes. So, project that we started in 2022, so it's been a year now, but a while. The main goal of this project that we did was to determine the feasibility of conducting an RCT testing the effect of prolonged exogenous ketone consumption in free living condition for 90 days in people living with type 2 diabetes. And these are really exploratory analysis, but we want to see if the prolonged exogenous ketone could improve glycemic regulation measured with A1C and CGM. So to do this project, we randomized 40 people living with type 2 diabetes in 2 different groups. One group was exogenous ketone 3 times a day. So basically before breakfast, lunch, dinner, they were drinking this drink, and or a placebo. More specifically, exogenous ketone was kinetic. We used 5 grams of free BHB plus 1 gram of 1,3-butanediol. And for the measurement, we got measurement at baseline, 45-day, and at 90-day. So we have A1C, we have also body composition. For the CGM, what we can see, we put the CGM 5 days before the intervention. So this gives us the pre-intervention, and then 9 days during, so we have the acute effect as well, and at the end of the trial. So we have the acute effect of exogenous ketone and the chronic effect as well. So if you look at the flow chart, total, we contacted 95 people, 40 were indeed randomized in both groups, and then 2 dropouts in placebo, and 8 dropouts in the exogenous ketone group. So data collection took place between 2022 and 2023. Male and female were equal in both groups. Diagnosis of diabetes around 6 years, A1C around 7.2, and BMI just over 30. So before looking at the efficacy, we want to see if people were compliant to the intervention. So these are the amount of ketone drinks that people did report every week for the whole intervention. So the maximum that they can drink is 21 because they have 3 a day for a week. And the minimum that we set for people was actually to consume at least 2/3, so 66%, which is around like 14 point something. So what we can see for both groups, it seems that throughout the intervention, there's a slight drops in ketone consumption, but it seems similar in both groups. And when you look at the total amount of drink consumed per week, the average, both groups also seem similar. Now, if we look at the A1C, so again, this is a feasibility trial. The main goal is not to do any statistical analysis on those results. We don't want to replicate type 1 error, and I don't think we're powered to see a change in A1C. So please interpret that with just be careful when you interpret this result. But visually, it seems that maybe ketone, so pre and post, did reduce a little bit more. And so I don't want to present any statistics, but I present the change with the 95% confidence interval, so you can interpret that however you want. But we didn't cross the 0 right here. So if you look minus 1.3 and 0.5, but we're pretty close, and it seems that there's nothing in placebo. But again, nothing really conclusive here. However, if you look at the glycemic variability, so just to make sure everybody's on the same page, 2 persons could have the same A1C, so I have 6.4, and Stephen has probably better than me, but let's say 6.2. So we have the same A1C, but our glycemic excursion might be really different. So the same A1C, some participants could go up for breakfast, go down really low, go up and down, which is glycemic variability. and the second patient could just be a little bit higher, but stays in a normal range. And when we look at people that have higher glycemic variability, increase their risk of micro and macrovascular complication. So if we look at our data, so again, this is preliminary, I don't want to make any conclusion, but I think it shows a really good decrease in glycemic variability. So this is standard deviation. So we can see in the ketone group, we can see the decrease, and in the placebo, we can see it's either stable, maybe even go up. And physiologically, that would make sense as well. So again, in a normal state, you have glycemic excursion when you have a meal, but if you consume beta-hydroxybutyrate or ketone supplements before the meal, this might help to reduce that glucose variability. So in one recent paper from John's lab as well, what they did, they took 10 people living with type 2 diabetes and they did a crossover trial. Either they were consuming exogenous ketone, I think it's 0.5 gram per kilogram of body weight, or a placebo. And what they did is a mixed meal tolerance test, and they look at the glucose appearance. So here on the graph at the bottom, what we can see is that this is so people in the control group, the excursion was higher after they had the mixed meal tolerance test. So people for the first 2 hours, we can see that people that consume exogenous ketone, the excursion is lower. But after, from 2 hours to 4 hours, what we see the exact opposite trend. So we did it here, yeah. So what we can see is that, yes, for the first 2 hours, glucose excursion is lower in the people that consume the exogenous ketone, but the last 2 hours, from 2 to 4 hours, we can see the opposite trend. So total glucose appearance in the blood, if we take 4 hours, is similar, but the excursion of glucose might be lower in the ketone group. So again, this is still, it appears to relate glucose absorption in adults with type 2 diabetes, which might help improve glucose variability. So the overall conclusion of that project, I'm still doing some analysis on the paper, so this is preliminary, but it seems feasible for people living with type 2 diabetes that want to consume exogenous ketone for 90 days, and it might give a slight improvement in glycemic variability. Again, we want to do a bigger RCT and a well-powered one with probably a different formulation of exogenous ketone. And this is what me and Dr. Littles are working at the moment. As also in the independent research program, we're doing a really small study right now that we're looking at the acute effect of exogenous ketone on immune cell function and beta-hydroxybutyrate relation of histone. So I won't spend too much time because we're running the project right now, but I have some backup slide with I think 4 or 5 parts have been as of now. But for that specific project, single arm study, no control group. People come in the lab, we take a blood draw, they drink exogenous ketone, 750 grams per kilogram of body weight. We wait 2 hours, we look at their BHB curve, and then we take a blood sample after 2 hours. We have different measurements. So usually, I don't know if you saw, but usually people always go over 3 millimole per liter with that dose. Most people are mostly around 5. And what we look at different immune cell functions. So once then we do whole blood and monocyte culture, where what we want to see in vivo if BHB increase, reduce the secretion of subsequent cytokines such as TNF alpha. We also do immunophenotyping for look at the certain surface marker in monocytes. And then Emily Goldsberg from the University of San Francisco will look at in monocyte and in PBMC, can beta-hydroxybutyrate in vivo do some epigenetic change. So mostly look at the beta-hydroxybutyrate relation of histone. And thank you to Dr. Islam for showing me the wet lab stuff. So I think the conclusion that we can make from today's discussion, the first one is that type 2 diabetes remission can be achieved with different strategy, but most people seems to go for a low carbohydrate diet to achieve this. So this has been shown in the DECIDE trial, the first study that I was talking about, but also in a real world setting. So I think today it's really important we all work with ketogenic approach, and I think it really underlines the importance of that specific strategy for people living with type 2 diabetes. Also, intermittent fasting might be an interesting approach for type 2 diabetes management, but we need further study or bigger RCT to really confirm those results. So this was, again, just a case study. We're doing a study to see if it's feasible to combine with exercise, but it might be a really cool approach for people that are further along the continuum of type 2 diabetes. And finally, prolonged exogenous ketone consumption, again, might be feasible, and we can discuss about that after, in people living with type 2 and could maybe improve glycemic variability. So just before finishing, I just want to say thank you for StarHR helped Michael Smith and FFQS for funding my postdoctoral fellow. Thank you for all the people in ML Lab. So this is the John's Lab. People are really nice. Thank you to all the collaborators and Stephen for organizing this conference. So thank you, everyone.